Hey boot campers, welcome back to another video. This is David, your guide to gastroenterology, and today we're going to be continuing our embryology chapter with a discussion about tracheoesophageal defects. So if you watched the first video about gut sections, you might remember that the foregut is what develops the trachea as well as the esophagus. And tracheoesophageal fistulas are a question that can absolutely come up in your STEP exam, but they're not going to give you a great amount of detail about tracheoesophageal fistulas during these questions. They mostly just want you to know these three different subtypes. And the three subtypes are pure esophageal atresia, pure tracheoesophageal fistula, and then esophageal atresia or EA with distal tracheoesophageal fistula. Now, two reasons that you'll see atresias come up in the gastroenterology section are going to be either a failure in recanalization, and again, that recanalization happens in week 8, or a failure in blood supply to the areas of the gastrointestinal tract, resulting in that tissue never forming. Now, let's talk about what they're going to ask you on the STEP exam about these. Before we get into the most common variant, which is esophageal atresia with distal tracheoesophageal fistula, let's first mention pure esophageal atresia. Just from looking at a picture of pure esophageal atresia, it's fairly easy to figure out what's going to happen here. We have our esophagus, it comes down, and then it doesn't connect to our distal esophagus. So our proximal esophagus and our distal esophagus don't connect. What that's going to result in is an inability for the baby to swallow fluids. So there's going to be polyhydramnios, and in addition to that, there's also going to be a gasless stomach. There will be no gas entering into the stomach, so you're going to have a gasless stomach, and importantly, because the esophagus does not connect to the trachea, there will be no lung congestion happening. Contrast that to our most common form of tracheoesophageal fistula, which is esophageal atresia with a distal tracheoesophageal fistula. A fistula is a connection between two structures, and in this case, the esophagus is connected to the trachea. However, it's notable that although the esophagus is connected to the trachea, it's connected to the trachea distally only. So things entering in through the mouth still have nowhere to go. That's going to result in a few different things, including, again, the inability to swallow amniotic fluid, resulting in polyhydramnios in utero. And then when the baby is born, the baby is going to be choking because it, again, has nowhere to put any saliva, drooling, vomiting, and also has a risk for aspiration pneumonia due to that distal attachment to the trachea. Because the trachea is connected to the esophagus, there's going to be a very prominent gastric bubble. Why is that? Because as air enters down through our trachea, it's going to be able to enter into the stomach via this distal fistula. And one thing that could absolutely come up on your STEP exam is the inability to pass an NG tube on these infants. Now, what they can do is either describe the inability to pass an NG tube, or they can give you a picture like this one. If you look here, the NG tube is coming down the esophagus, and then it loops right back up around. So you can see that white outline of that NG tube. That is what the inability for an NG tube to pass looks like. It's going to come down and then right back up again because there's nowhere for it to go within this esophagus, right? It can't continue to go down into the stomach. And then now that we've talked about our different forms of esophageal atresia, the only thing remaining is our pure tracheoesophageal fistula. This one, there's no esophageal atresia. Instead, the esophagus is patent throughout. However, there's a connection to the trachea. And this connection to the trachea allows for fluids from the esophagus to enter into the trachea, both distally and proximally. So there is a significant potential for aspiration pneumonia. And also, because there's a connection from the trachea to the esophagus, we again have air entering into the stomach, and so there's going to be a very prominent gastric bubble in these newborns. So to very briefly recap, how are these going to present differently in STEP questions? Let's highlight the differences. In pure esophageal atresia, when these infants are born, there will not be a gastric bubble. There's no way that you can have a connection to the trachea in pure esophageal atresia. With distal tracheoesophageal fistula, you will have a prominent gastric bubble because you do have a connection from the trachea to the esophagus, and there's also a significant risk for polyhydramnios because there is nowhere for the baby to swallow anything because of that atresia up higher. And then meanwhile, in pure tracheoesophageal fistula, you will not have that same polyhydramnios risk. However, you then have a more significant risk for aspiration pneumonia. That's it for this video. I hope you all enjoyed it, and I'll see you in the next one.